Welcome to another third Wednesday of the month, and it's time for our coffee chat session. And of course, this is where we get expert panelists to share worthwhile information to us to make the lives of our seniors, our elders, and of course, ourselves as well easier and better. Of course, my name is Dexter, your host today, and I'm super excited to introduce to you our rock star speaker, Darcy Brennan, the brains and heart behind Something to Say LLC. Of course, Darcy isn't your average speech language pathologist, guys. She's a shining star in the world of communication and swallowing wellness with tons of experience in everything from ICU to skilled nursing facilities. She's been on the front lines of making lives better. And as I've mentioned a while ago, she's the founder of Something to Say LLC. Darcy's not just about fixing problems. She's all about education and top-notch services. Oh, and of course, um, yeah, I mean, that's a mouthful, and I won't keep keep you guys waiting for long. Today, she's here to drop some serious knowledge bomb on swallowing and communication wellness, and you'll be able to ask your questions along the way. We'll just be giving you cues, of course. Ready your questions, you can type them out, or once we give you the cues, you can unmute yourself and, share your question directly. Anyway, grab a seat, get comfy, and live. Let's give it up for the one and only Darcy Brennan. Let's go.
Thank you so much for that warm welcome, Dexter. I really appreciate it. I'm going to go ahead and share my screen. Thank you all for having me here today. I really appreciate it. I'm very passionate about these topics. And so whenever I have the opportunity to spread some knowledge and educate, I jump on that opportunity. So like Dexter said, I started my own private practice called Something to Say LLC. And I service Washington, D.C., Maryland, and Virginia, so the DMV. I am a speech pathologist. And today we're going to talk about swallowing and communication. And if you have any questions, like Dexter said, you can write them or unmute yourself and ask. We're going to start with swallowing and then have a little break to ask some questions, and then we'll go into communication after. All right, so what is a speech language pathologist? You may have heard SLP, you may have heard speech therapist, but our name is a speech language pathologist, and we assess, diagnose, and treat speech, language, and cognitive communication disorders in a variety of healthcare settings. And so when we think about speech, language, and cognition, those are kind of all the skills you need for communication. And then swallowing is also stuck in there. And people are always like, why swallowing? And really the same parts to produce speech and voice is the same structures you use for swallowing, but just in different ways. Who we work with, we're all over the place. Sometimes people know speech therapy working with kids, but my primary focus is working with adults. And we can work with head and neck cancer patients, individuals living with Parkinson's, people recovering from strokes or traumatic brain injuries, dementia, Alzheimer's, cerebral palsy, myasthenia gravis, and tracheostomy and ventilator patients. So we service a lot of different populations, and our role in each one, it can be really different based on where we are and where the patient is medically. And then lastly is, where do we work? We work in acute hospitals, acute rehab facilities, outpatient settings, home health, skilled nursing facilities, and assisted living and private practices. So basically we're everywhere. And yeah. All right. So like I said, today we're going to start off with swallowing. And I always love to provide education with swallowing because it's such an abstract concept that we do on a daily, multiple times a minute. And it's great that we can do it until it doesn't work. And that can lead to a lot of detrimental kind of domino effect of other problems that can happen. So Today, or right now, we're going to talk about normal swallowing. And I like to talk about normal swallowing before we get into abnormal swallowing, because it's good to understand how just the system is supposed to work. So speech therapists, we break it down into different phases of a swallow. So the first phase is what we call is the oral phase. And basically that is the chewing of the food, the manipulation of the food, um, transporting the food, which we call bolus, so that we can initiate a swallow. And each of that oral phase is going to be different based on the type of texture or consistency of food or liquids that you're having. The next phase is what we call is the pharyngeal phase. And basically that's the throat part of the swallow, which we can't see, but we can understand signs and symptoms. And what the pharyngeal phase is basically this swallow initiation. And when this phase starts, it's reflexive, meaning you don't really have control over it. It either happens or it doesn't. And about 5 things happen. First, the vocal cords close to protect your airway. There's a funny little cartilage in your throat as well called the epiglottis, and that inverts so that it also protects your airway. Your soft palate that's in your mouth also elevates so that food doesn't go up your nose. And then lastly, I didn't actually put it here, is the muscle that keeps the esophagus, the food pipe, closed when you're breathing and talking, relaxes so that food can pass from your throat into your food pipe, your esophagus. So that is a lot that happens, and it happens really fast. And so when there's a breakdown or impairment with that, that's when you kind of see some signs and symptoms or later complications that we'll talk about. And then the last phase is called the esophageal phase. And that's when food passes into the esophagus or the food pipe and then to the stomach. Speech therapist, this is kind of when our job ends, and that's when a GI doctor kind of picks up in terms of scope of practice. But it is impacted because people who may have esophageal dysphagia or swallowing problems can sometimes either come back up into the throat or cause discomfort, causing other things to happen as well. So I have a video here of a normal swallow. It's my swallow, it's my throat. And just as a heads up, this moves, it's dynamic and it moves. So if you get startled easily, just be aware of that. I one time showed a video and people didn't expect it to move and they jumped. So I'm just gonna give that little update. So this, like I said, is a normal swallow. And if you see here, you see a little V shape, and those are the vocal cords. And your vocal cords kind of act as a doorway, a protective mechanism, so things don't go past it, don't go below it. That's when it enters your trachea, and then that's what leads to your lungs. And if you have any healthcare professionals here, people probably have heard the word aspiration. And that's when food or liquids goes beyond the vocal cords down, heading to the lungs. But before that happens, your vocal cords hopefully will have the proper response of closing and coughing. So hopefully what happens is you cough it before it actually goes down into the way. So anyways, I'm going to play it. And there's a period of when the actual swallow happens, and we call it a whiteout because that's when the epiglottis, like I said, flaps down to also protect the airway. So I'm going to play it and hopefully there's no problems. So they're moving. You can see my vocal cords kind of moving. I'm just talking here and breathing. That was a swallow. That was also a swallow. And I'm kind of looking around because you can see that the vocal cords close and they move, but there's still a lot of other crevices and pockets that food can hang out in. And this is a swallow study that speech therapists do to really objectively assess someone's throat phase of the swallow, the pharyngeal phase of the swallow. And we'll get into that a little bit more. But I like showing this video just because it's this abstract concept that, like I said, we just do it. And it's a very complex system, and there's a lot of things that can happen when it goes wrong. All right, I'm gonna exit. eye here. Let's see. All right. All right. So presbyphagia is what is a normal change in the swallow mechanism in healthy aging adults. So sometimes this is what we consider if someone we're seeing in a hospital and they are in the older age area. So we have presbyphagia, which is the normal age-related changes to swallow. But if you couple that with a stroke or Parkinson's, that's when a swallow could get a little bit more severe. But just for general education, as we age, just like our eyes and our ears get a little bit less efficient, our swallow does too. And so typically, sometimes it can be a little bit slower. The swallow initiation can be, I don't want to say delayed, but it may just take a little bit longer. There could be more residue in the mouth or the throat, more frequent penetration, which is when things try to go down the wrong pipe, but you respond properly, and that's by coughing. So we have penetration, which is when things try to go down the wrong pipe to the where the vocal cords are, and then aspiration is when it goes beyond the vocal cords. There's also sometimes a delayed and shorter upper esophageal sphincter opening. So what that means is the muscle that opens to the food pipe doesn't open as fast, or the length of that muscle is not as wide. So you may end up with a little bit of food residue in your throat, requiring maybe another swallow. Or earlier food entering the throat. So sometimes when we think about the oral phase of the swallow, being able to control it in your mouth before you start the swallow, sometimes that can change a little bit. And then more frequent aspiration, which I don't want to scare you, because just because you aspirate does not mean you can get a pneumonia. And I'll get into that a little bit more. But this is just so you can understand that as we age, like I said, just like our eyes and our ears get a little bit less efficient, so does our swallow. And so sometimes when we look at patients that are in the hospital that just had a stroke, that are, let's say, in their 80s, they might have a little bit of presbyphagia, and they might have some swallowing impairments from the stroke as well. So that was a lot of talk about normal and functional swallowing, but now we're going to get into the abnormal swallow. And the medical terminology for abnormal swallowing is called dysphagia. And dysphagia, it can occur at one of the phases that we discussed, or in more of the phases. So it can be one or multiple. And some general signs and symptoms of dysphagia are food and liquids spilling from the mouth or the nose. Coughing is probably the most obvious one, which can happen before, during, or after the swallow. Persistent throat clearing, food residue that's remaining in the mouth, which sometimes we refer to as pocketing if it's kind of left in their cheeks and they're not sensing it or they're not feeling it. Difficulty or excessive chewing. Another kind of overt sign is a wet or gurgly voice quality. So if people are eating and they're then talking at the same time or talking after, you can kind of hear this wet, gurgly sounding voice. And that could indicate food remaining in the throat. Avoidance of food or poor appetite. Sometimes also as we age, the taste gets a little bit diminished. And so the food that we used to once love just doesn't taste as appealing. Unexplained weight loss, excessive time to complete meal, shortness of breath is another sign. And this is a lot, but it's just kind of different signs and symptoms that we look at as speech pathologists. But if you are a caregiver here, or if you might be someone experiencing dysphagia for whatever reason, or a healthcare professional, these are kind of the things that you may notice. And then that may warrant a speech therapist. And sometimes it could be swallowing, and sometimes it could be something else. But it's good to kind of know these signs and symptoms to be aware of, because the complications, like I said, can be detrimental. So what are the risks of dysphagia? So like we mentioned a little bit earlier, is aspiration. And that's when food or liquids goes below the vocal cords into the airway or into the lungs. Now, aspiration pneumonia, that's what people should be afraid of. And that's where the infection, that's a pulmonary infection from the aspiration material. So if you're a healthy individual and, if I aspirate, I probably won't get a pneumonia. And I'll tell you why shortly. But it's really the aspiration material that leads to infection or buildup of bacteria that leads to the infection. And there's different kind of risk factors that speech therapists know about, and we try to educate people with it so that if you aspirate one time, nothing probably will happen. Weight loss is another risk of dysphagia, and that can kind of have a domino effect into dehydration, malnutrition. Then they're fatigued and tired, and so then that could lead to a fall or a UTI, and so it kind of can have a domino effects of other things really, and when the underlying effect is dysphagia, they're not eating enough or not safely enough. And then the most other obvious one is choking, and that's when there is an obstruction of the airway. So with all that information, what does a speech therapist do? So depending on where we see the patient, whether that's in the ICU, as an outpatient, it can be changed, but in general, when someone's kind of concerned of a dysphagia or they're losing weight, what the speech therapist will do is we'll go in, we'll do a thorough chart review of kind of what's going on medically or what the complaints are. And we'll do what we call a bedside swallow evaluation. And basically what that is a speech pathologist is making a hypothesis of what we think is happening, provide education, maybe make a judgment or adjustments to the type of texture that they're eating. For example, if someone's on a regular texture of food, maybe we want to do something a little bit softer, what we call soft and bite size, so that it's a little bit easier for someone who may have, let's say, difficulty chewing for whatever reason. So we might make those adjustments there. But really, in order to understand what's happening in the throat phase, which is really, I think, they're all important, but the one that would really lead to a pneumonia is the pharyngeal phase, and that's to complete an instrumental swallow study. And the two swallow studies that we do as a speech therapist these are acronyms, but FEES, which stands for fiber optic endoscopic evaluation of swallowing. And that swallow study that I just mentioned, that's what the video that I showed earlier, that's a FEES. And basically how to do that is a little camera and a little endoscope goes up and around the nose. So we get that bird's eye view of the throat. So we see the vocal cords, we see the epiglottis, and we give food during the swallow study and we see exactly what happens. The other swallow study is what we call a modified barium swallow study. And that's basically a video x-ray. So what you do there is you go to the radiology suite, you have to drink some barium so they can see it on the x-ray machine, and then we see where it goes. They're both important. They're both best practice, evidence-based. A reason why speech therapists might choose one over the other is could be a whole nother conversation, but really it's either one of those instrumental swallow studies that's really going to allow the speech therapist to see what's happening in the throat during the swallow. A lot of the times in hospital settings or like skilled nursing facilities, people are like, they're aspirating, but they may not be aspirating. They may have a dysphagia, but they're coughing in response. And that's good. I'd rather have someone cough and clear their throat versus having it just sit there and then having nothing happen and go down to the lungs. Another thing that speech therapists do is we educate on the findings and the recommendations. And based on where the impairment is or what the diagnosis is, we may educate on swallow strategies, specific exercises, or modifying the texture of the food liquids. So sometimes you might hear thickened liquids or puree textures, and that's what I mean by that. Or compensatory strategies, which is you're eating a regular texture, but make sure that you're taking smaller bites or alternating food and liquids. So that's what we mean by compensatory strategies. And in order for a speech therapist to really guide, the best recommendations is to obviously observe the patient eat, find out what their symptoms are, but then also doing a swallow study. And then the last one that I'm really, I guess, think is really important as well is the risk management. And like I said, with aspiration, that does not mean you're going to get a pneumonia. And what people can do that's more in their control is having really good oral hygiene. That's one factor that's going to reduce your risk of developing a pneumonia. The second is staying as physically active as you can. And then your general immune system. So those are the three risk factors in terms of what we think about when we kind of consider someone at risk for getting an aspiration pneumonia if they have a dysphagia. So if you can do all those three things of getting, or really two, because sometimes we can't help our immune system, but if we have really good oral hygiene and we stay as physically active as possible, that's going to help the lungs kind of filter out what's not supposed to be there before it kind of just sits and develops into an infection. So a lot of times, sometimes people in that are bed bound I might have to be a little bit more conservative with them in the fact that if they're laying down all day on, switching sides throughout the day, if they aspirate and we see that on a swallow study, we really want to make sure that whatever we recommend is safest, because people that stay on one side, the food just sits there and it can kind of develop into a pneumonia a lot easier than someone who's moving, they're working their lungs, and it's a lot easier to, like I said, filter out. So that was a lot of information. But does anyone have any questions based on all that information? No?
Looks like none so far, Darcy, but
Okay.
Susan is requesting, I think, to see
Mhm.
again the video of the
Absolutely.
swallowing. Yeah.
Absolutely. So I'm going to go back. Here it goes. I'm going to play it again, and I'm going to pause it right here. So just for like anatomy reasons. So you see the V shape. Those are the vocal cords. Below that is the trachea, the windpipe. These little joints, those help move the vocal cords, but really it's, in terms of a voicing perspective, it's really the pressure from below, from your lungs, that generate the vibration of your vocal cords. So when you're talking, your vocal cords come together and they vibrate. And when you swallow, they close really tight to protect your airway. So your brain and your body do a lot to protect your airway, which is important. So I'm going to play it again. Let's see. That was actually a burp. So you can see the UES open real quickly. And with this type of swallow study too, is we give food during it. And so we can, and typically we'll diet like with a little bit of food coloring so that we can really see it on the video. And like I said, we look exactly what happens. Sometimes it may not be going down the wrong pipe. It just might be some residue in those little two pockets you see on the left and right side. And it's just sometimes needing another swallow to clear that. But as a speech therapist, we're kind of looking at why is that happening? And that can be because of an esophageal component. It could be because of an oral phase component. It could be because of timing and coordination of a swallow. And so that's where the speech therapist really kind of works out what's the underlying deficit so that we can kind of facilitate different responses for swallowing. Does anyone want to, anyone want to see it again, or was that okay?
Yeah. I think Barbara is raising her hand here.
Perfect.
Yes. I've got a question, Darcy. As you're playing that in there, what happens if food does get stuck back in those pockets? I mean, I know you mentioned something about coughing, but how do you extract that out? Is there some type of procedure? And then what is the preventedness from happening again?
So great question. So what I'm going to do actually is I'm going to annotate. So that's where we don't want food to go down. If you're saying like these little pockets right here, those we call as piriform sinuses. If food's a little bit of, so we also can see, is it a little bit? Is it just a little trace amount, or is it a lot? And if it's a lot, that's when it can be like, all right, let's adjust something, because food sometimes can spill over they're called the arytenoids, over the arytenoids into the laryngeal vestibule, your airway essentially. Now, if we see it on the camera, normally what we'll do is we'll see what the response is. If it's a little amount and then they just swallow it, no big deal. If there's a lot, then we watch exactly what happens. Now, the response we want, Barbara, is to cough. If we see a lot, and let's say it's going all down here, and they're coughing, and it's not being cleared with reswallows, then we're going to keep prompting them to cough, see if we can reduce that residue, see if we can get rid of it. But if it's persistent and it's not being cleared, then typically if the swallow is really severe in that way, we won't do any, like under trials. If the swallow is really severe and we see consistent aspiration, on like, let's say ice chips, and then we try a little bit of applesauce or a little bit of thickened liquids, and all that's aspirated, then we just stop and we'll say, okay, we recommend NPO, which is nothing by mouth. Typically that really just happens in like an acute care setting, like a hospital or an ICU. Now, another thing about this type of swallow study is we get to see the vocal cords and how they move. So sometimes people who just got intubated, or they were on a ventilator, this might be really swollen from having a tube down your throat. So that could impact sometimes. So in this swallow, you can see my vocal cords come together really well. Someone that may have immobility or left vocal cord paralysis, maybe the vocal cords aren't moving or they don't come together as well. And so sometimes we can see that. And then if they don't have a functional enough swallow in every other realm, then we may see aspiration or penetration of material. So we're looking at a bunch of things. We're looking at what the anatomy looks at even before swallow, what their sensation is to that. So what their response is when a swallow doesn't go right. A lot of the times, sometimes stroke and recently being intubated, those are sometimes the two big things that could impact sensation. So if you're not sensing it, we call that silent aspiration, which is when things go down the wrong pipe and there's no response. A lot of the times though, people will have a response. They'll cough, or they'll have watery eyes when they eat. So hopefully that answered your question. Now, in terms of procedure to clear the material, normally if we see a very, very, very severe swallow of aspirated material, we would communicate that to the doctor, monitor really heavily, watch their white in a hospital setting, look at their white blood cells, see if that gets elevated. Or this is a doctor, but maybe they'll start them on antibiotics. But honestly, most people that are in the hospital, I feel like is on some form of antibiotic when they're there. But there is called, to remove secretions out of the airway, is called a bronchoscopy. And that sometimes it's not really done for just like, let's say if we saw one swallowing event, they won't do that. But if someone has a lot of congestion in their lungs, and it could be food related, or it could just be other pulmonary things going on, and they can like suction it out, and that's called a bronchoscopy, to suction stuff out. Yeah. All right. So any other questions?
I think we're clear, Darcy.
Okay, so I'm going to hopefully stop this annotation. Sorry. Okay, there we go. Oh no, how do I get it? I'm just gonna erase this real quickly. Okay. So now we're going to switch gears into cognitive communication. And cognitive communication disorders are problems with communication caused by cognitive deficits rather than a primary language or speech deficit. So what that means is when we think about communication, we think of sharing a message. And sometimes that shared message could be impacted if someone has a language impairment, which is called aphasia, or their speech, their intelligibility of how they produce their speech sounds or their voice is impaired. So it's cognitive communication isn't because of language or speech, it's because of cognitive processes. So it might be, so some of the cognitive processes are attention, being able to attend to a conversation, memory, perception, processing speed, problem solving, thought organization, being able to organize your thoughts. Language is one, orientation, metacognition, which is the ability to think about your thinking. And so there's kind of a lot of cognitive processes that we do. And when we think about cognitive communication, speech therapists will kind of be able to tease out where there might be some deficits and where their strengths are, so that we can help them communicate as effectively as possible. And so your brain is a very, very complex system. And so there might be a problem with attention, which is going to lead to other problems. And a lot of times when I work with people with cognitive deficits, they may have difficulty with attention, being able to attend to a structured task or multitasking. And the best example I can think of this is, and then they'll say that their memory is bad, but it really may be more of their attention's not great, impacting their memory. So the most, I think, relevant example of this is if we're multitasking. Let's say we come home and we're talking on the phone and we have our keys and we throw our keys while we're talking on the phone. And then later we're like, oh, I don't remember where I put my keys. It may not be really a memory deficit of where you put it. It might be more of your attention to that task was not there. You weren't attending to it. And so therefore you don't remember where you put your keys because you didn't attend to the task, because you were doing something else at the same time. So before you can really do any cognitive process or any thinking, attention is really kind of like the baseline, the foundation of all these other complex tasks. Yeah. Any questions so far? No?
Yeah, Darcy,
Yes.
are there instances where memory impaired people tend to forget to swallow, or along that line?
So great question. So a lot of times in Alzheimer's or dementia, people may not have, let's say, a throat problem with their swallow, the pharyngeal phase of the swallow. It might be more of the attention to the task, their willingness to eat, even self-feeding. If they can't do that, then that puts someone responsible for that. And so the best way I like to actually describe this is the first part of the swallow, when we talked about the oral phases, is controlled by the front part of your brain. So that's your sensory system, your taste, your chewing. That all prepares for the second part of the swallow, which is controlled by the brain stem. And so when people have dementia or Alzheimer's, that front part of the brain is typically not sending as many signals, is just less quote unquote activated. And so sometimes people may not have a pharyngeal impairment, but the taste of it or their ability to manipulate the food or initiate a swallow could be impacted. In terms of memory of to swallow, a lot of the times it's more cognition that's impacting them to swallow. So they're probably swallowing their saliva throughout the day, But when it comes to a task, such as like a mealtime, it may be that there's just sensory input of the food is just not as optimal as it was before. So the taste and the texture all provide a lot of information to the brain to prepare for a swallow. And when that's kind of diminished, then that's when you see people holding their food or playing with their food or just keeping it in their food because they're just not giving their brain that sensory input that it needs to initiate a swallow. So hopefully that helped. Any others?
Thank you. Yeah,
Yeah,
we're
no
clear.
problem. Okay, all good. All right. So what you may notice if someone's experiencing any cognitive communication changes is, I think the biggest one and sometimes the earliest one is trouble participating in discussions. So multiple people talking really fast with multiple topics can be difficult for that individual to follow, process, and then prepare what they want to say. So they may be a little bit more quiet in terms of, at the family dinner table, they might be talking a little bit less. They may have a hard time remembering conversation or experiences. This could be you called them on the phone and they're telling you the same story that they already told you. Difficulty understanding conversation or instructions. So what this could look like is, maybe you're going to get food and you're like, hey, can you go get the keys in the wallet? And that sequencing of task is just a lot harder for them to plan and execute. Another one is trouble conveying thoughts efficiently or effectively. So they may use what we call is like circumstantial speech. So they don't have a nice organized thought, or they'll use words like thing or that, or very kind of not detailed words, which is going to impact their communication of what they're trying to say. So they may be like, oh, I need this over there. And yeah, I really need that. But there was really no message in that. And so as a communication partner, you may have to have some either ask your questions a little bit in a yes or no question or provide them with two options. But we'll get into that. And then another one is difficulty reasoning and making decisions. So that's sometimes another one is if you're like, hey, we want to go out to dinner, where should we go? That might be really challenging for them. They're not trying to be difficult. It's just them thinking and planning and thinking of all their options. It's just going to be really challenging for them. Unable to respond in a timely fashion. And that's when it's really the caregiver or whoever's with them takes a lot of patience in order for them to kind of gather their thoughts and plan what they want to say. And then another one is they overestimate their abilities and independence. I always take this with a grain of salt because, you live your whole life being independent, you work, you have kids, you do your job, and then you're at the next phase of life where you're not as independent. And so it's hard. It's the sense of control that changes, as people age or if they have a diagnosis that impacts that. And so really kind of being compassionate and understanding that this was never a problem for them, however long ago. And so and that's basically taking away some of their control of, just small decisions that we take for granted every day. And so sometimes I think that's just personality and changing and adjusting, but then you'll have people that clearly cannot walk, and they'll be like, yeah, I can walk. That's no problem. And you realize you're like, well, you really can't. So there's a spectrum of that in terms of overestimating their abilities and their independence. So strategies that you can do as a caregiver or an aide or a nurse to help facilitate meaningful communication is allow the person extra time to process what you said. I know 90 seconds feels like a long time. It doesn't have to be that. But give yourself a little bit of time for them to really think and process what you said, but also for them to plan what they want to say. Provide information in shorter chunks. So if you're providing directions, break them down into a small step. So what that could look like is instead of, oh, we're going to out for lunch or we're going shopping. Can you go do this, and that? The first step might be, let's go get changed. And then once they're done changing, then it can be, oh, did you bring your medicine? So really breaking down the steps to really single steps at the same time during a longer complex task. Another thing could be write down key information and instructions, or encourage them to write it down themselves. So visual aids, calendars, maps, lists, those all work, especially when memory is difficult for them. No one has a perfect memory. And so using your 5 senses helps kind of facilitate that. It helps facilitate them to recall things. So if you just hear something one time, it's most likely going to go in and out the ear, because I mean, no one can really even do that perfectly with everything in life. But really having external cues to help facilitate reminders. And so for one thing that speech therapy can do is sometimes like medication management. And, they might have a nice pill box and they do that, but putting in an area that's going to have them recall it. It's not going to do any good if it's in the closet somewhere in the bathroom. So creating an environment that's going to help them recall things, or having it write it down themselves. So like I said, using the 5 senses, the taste, the smell, the hearing, the vision, and the touch can really help for communication. And depending on who you're working with, that's going to look different for each person. So there's not really one way of doing this. So someone with maybe late Alzheimer's who's nonverbal because they can't get their words and it's the late stage, sometimes just less is more, by just playing their favorite song, or something like that they could smell, or just holding their hand. Sometimes especially maybe late stages of diseases, less is more, simplifying what you're saying so that they can kind of understand. So what a speech therapist can do to help with this is help set goals, provide therapy to strengthen skills, compensate for deficits, and then also help the person and the caregiver understand what's happening, and try to get you back to participating in life. And like I said, this looks different for everyone in terms of the spectrum of where we see people. So, what my goals are for someone in an ICU is going to be a lot different than my goals and their goals in a home setting. But sometimes it's just creating different habits of what works best for the patient or the client, as well as their caregiver. And so, that takes a little bit of time to kind of figure out what's their strengths, what's their deficits, in terms of cognition. Where is it? Memory? Is it attention? Is it one step they're fine? Or is it multi-steps that they kind of, you see the breakdown? And that's where an SLP can kind of help navigate those situations. And that is it. Thank you everyone for your time. I know everyone has really busy lives, but I do appreciate everyone's time. And if anyone has any questions, my contact information is right there. So feel free, if you can't think of a question now, but you think of a question in an hour, feel free to reach out. But if there's anything else, I'm open for questions.
Awesome. All right, guys, if you've got any questions. So Robert here has a question. Are
Yes.
there any unique features of difficult swallowing with late-stage Huntington disease patients that are amenable to treatment?
So in terms of treatment methods, it's sometimes there's exercises to improve, and then sometimes it's compensation. For Huntington's, I'd really have to figure out kind of where the deficit is. Is it more of an oral phase because it's a movement disorder, and controlling the food in the mouth might be challenging, or is it really a coordination impairment of the timing of the swallow? So it really depends on the patient. I think the biggest one is in terms of we want to make sure that your swallow safety and your swallow efficiency. And when I say swallow efficiency is whatever you're eating, whatever texture you're on, is it efficient? And sometimes education and strategies such as, okay, you're okay with regular solids, but you get really fatigued with that and it takes a long time. So let's maybe have a meal where you have a harder regular texture food and your side could be more of like a puree where it doesn't require as much chewing, manipulation, leading to less fatigue. And then you eat more, you consume more safely. In terms of treatment methods, it, like I said, it really just depends on where the deficit is, and then kind of go from there. But I do know it's a movement disorder, and so sometimes the control of the food is a little bit challenging. So it could be positioning that helps. It could be the type of texture that you're getting. But yeah, I know that probably wasn't answering that specific question. It just really depends on where the deficit is.
Okay. Karen here is saying thank you. This was informative and well presented. Susan is asking, can you review which type of doctor deals with swallowing problems?
Great question. So, speech therapists are really the swallowing specialist. Now, depending on, like I said, those phases, if it is esophageal dysphagia, I don't know if anyone has ever heard of a diverticulum, and that's basically a pouch from your esophagus. And so what happens is people will swallow and then, but the pouch is there in the esophagus and food goes there and it causes a lot of regurgitation or backflow, causing people to either cough or be having this sensation of, oh, food stuck in my throat. And in that case, it probably will be a speech therapist that does, let's say, a swallow study, and then we see that, and then we refer to a GI doctor. But really, it's the speech therapist that's kind of the specialty in terms of swallowing. Now, we do connect with other people. So dietitian is another big one that we work with in terms of making sure calorically they're eating enough. So speech therapists are thinking about how things are going down and what's safest. And then dietitians are really thinking about how much you're eating for whatever reason. And then GI doctors are another one that we kind of collaborate with if necessary. But yeah, really the speech therapists are the specialty in terms of the who's going to treat that. But yeah. Anything else?
All right. So we have one more here.
Yes.
Do you have an office or do you come for home services, and does insurance cover your services?
Great question. So I go to the home. I don't have a brick and mortar, which I like going to the home because I find it's most practical and realistic. So I go to the home. And then in terms of insurance, I am in network with Medicare Part B. So if you have the generic Medicare Part B, then I'm covered under that. And then private pay. But what I typically do in those situations is provide you with a super bill, and then you can submit it to your insurance. And if it's a PPO, most times they will cover a percentage. If it's an HMO insurance, HMOs are really strict with you can only do what's in their network. So it probably won't be reimbursed. But a lot of times if you have a PPO, it will get partially reimbursed. Yes.
Okay, here's another question from Gil. Do you recommend a life vac or similar device for home use, RE choking issues?
I see. So the thing that like you put over your mouth and you suction it out. So if that's, I have one, I bought one for when I do, dysphagia therapy in people's homes. To be honest, I have never had someone choke. I've had more people aspirate than have a, I've never had someone choke on me. That is to say that that can't happen or won't happen. But I mean, it can never hurt to have one, especially if you've had an episode of choking. I would say it's always good to have.
All right.
Yes.
I guess we have no more questions here. Guys, if you
Yes.
have, we still got a few minutes if you have something there. Anyway, if if you guys have enjoyed our coffee chat today, your feedback is of course valuable to us. I'm gonna be putting a link in the chat box if in case you're privy to giving us a bit of a review, okay, or a feedback here. And yes, of course. Thank you, Darcy, for sharing your experience and knowledge and expertise today. You truly are a blessing. And yeah, guys, the contact details and organization information is at the chat box as well, and so you can copy it as well as in your screen. So looks like we are clear of questions here. I'm just gonna be inviting you. So this is the last announcement that I would have for you guys. Join us next month, third Wednesday once again for another coffee chat, and it's gonna be about respite, of course. So this is for caregivers with seniors who need assistance in the same household, okay? And we're gonna teach you how to apply for respite coordination from ARC Montgomery County. And I've included the link for you to sign up as well for next month's coffee chat. Um, yeah, that's it, guys. Thank you for being with us. And
Thank you,
Barbara.
Dexter. Thank you, Dexter. I appreciate it. Actually, I am very familiar with that life back. I actually put a picture of it in the chat. I
Yeah.
personally purchased one for my mother, and I did it for all of my children and the grandchildren. So they come with a small mask and they come with a large mask. So this is a great tool to have. You can get it on Amazon. We're not promoting it, but I can stand by it. If you've seen things, you can put it on YouTube. But it's just a choking type thing. And I'll give you an example. My mom had Alzheimer's and she would pocket food. And that was one of the questions that I was asking, because she pockets it and she forgets to swallow. And a lot of the diseases, the Huntington's disease, the Parkinson's disease, these are very careful situations and unique situations. And Darcy is very good at customizing to what your particular situation is. And I would encourage each and one of you to reach out to her. She's a great resource. Check out her website. I am totally impressed with her. She's a great speaker. She knows her stuff. And thank you all for joining at Visiting Angels. We are here to educate, to help, tell others about it. We do this every month, like Dexter said, and we appreciate your time. And you can look at our YouTube page. Dexter has it previous different coffee chats that we've had. So check out the topic. Darcy, you're going to be a regular because I know you're awesome. So we're going to ask you next time to come back again and educate us. And one more chance. Anybody else has any questions? If you want to go ahead and send them, we'll get them to Darcy and make sure. Thank you again.
Absolutely. Yeah, thank you so much, Barbara. And just one last food thought. As a speech therapist, with recommendations and stuff, my goal is to always provide obviously safety, but quality of life reasons of really taking in what the patient wants and weighing what the patient wants with the risk and benefits. And then sometimes it's a lot of education in terms of what you can do to, yes, keep eating everything you want to eat, but let's do it safely, and modifying what you can do to still optimize your quality of life in terms of nutrition and swallowing, but do it so safely. And then also with the life back too is we swallow about 4 cups of saliva a day. So we're swallowing 2 to 3 times a minute. And we're not meant to think about it. Because if we had to think about, all of that, we wouldn't be able to navigate the world around us. And so it's always good to have one because your swallow, I mean, everyone has had that experience where something tried to go down the wrong pipe and you cough, 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 cough. So even people who have a normal swallow, there's always that risk of choking. So like Barbara said, it's always good to just have. And if you don't need it, great. But if you ever were in the case of having it, you had it. But that is all I guess I have to say. But like I said, thank you everyone. Thank you Visiting Angels for hosting me. I really do appreciate it. Anyone have questions, feel free to, like I said, reach out. And I hopefully will hear from you soon. And thank you so much again.
All right, guys. I guess this is it. Have a great day, everyone. Bye-bye.
Bye, thank you.
At Visiting Angels, we're committed to enriching the lives of elders and their significant others. Our monthly coffee chat sessions aim to make your lives easier and better by providing quality information from our expert panelists. We're here to elevate your quality of life, offer practical wisdom, and ensure you have access to valuable insights. See you again next third Wednesday of the month.